So hydrocephalus, it is a combination of two words. Hydro means water and cephalus means brain. That's the reason it is also called as water and brain. It is also called as water and brain. So here in hydrocephalus there is accumulation of CSF, accumulation of CSF within brain ventricles. So in hydrocephalus there is accumulation of CSF, means cerebrospinal fluid, within the brain ventricles. Ventricles are irregular cavities which is located within the brain parenchyma. So here by hydrocephalus, the water, it indicates the CSF. A CSF contains approximately 99% of water. So it is the accumulation of cerebrospinal fluid within the brain ventricles. But how you will properly define hydrocephalus? Now let me write the proper definition of hydrocephalus. So it is a condition. It is condition in which either there is excessive production of CSF or there is blockage of CSF flow. There is blockage of CSF flow resulting accumulation of CSF within brain ventricles, thus leading to increased intracranial pressure. So what is hydrocephalus? Hydrocephalus is a condition in which there is excessive production of CSF, cerebrospinal fluid, or there is blockage of CSF flow. Ultimately it leads to accumulation of CSF within the brain ventricles, thus it leads to the increased intracranial pressure. Now what is actually CSF? So CSF, it is a cerebrospinal fluid, and actually it is called as cerebrospinal fluid, and it is also called as lymph of CNS. It is also called lymph of CNS. Now, where does the CSF is produced? So CSF produced by choroid plexus. So the cerebrospinal fluid, it is produced by choroid plexus. And what is choroid plexus? Actually these are the bunch of capillaries. Now what is the normal pressure of CSF? Now the normal pressure of CSF, that is a 10 to 15 centimeter by water whenever a person is lying in a supine position. But if we talk about a standing position and that condition, the CSF pressure is 30 centimeter per water. So the normal CSF pressure in supine position, that is 10 to 15 centimeter per water. But if the patient is lying in a standing position, and that condition, the CSF pressure is 30 centimeter per water. Now, what is the rate of production of CSF? Now, let's discuss the rate of production of CSF. Now, CSF rate of production of CSF. So it is 0.5 ml per minute, or it is 20 ml, it is 30 ml per hour, or it is 720 ml per day. So it is very important, the rate of production of CSF, it is considered as 0.5 ml per minute, or 30 ml per hour, or 720 ml per day. Now, out of 720 ml per day, the 500 ml, it is absorbed by subarachnoid villi, which is present in subarachnoid space. So the 500 ml, it is reabsorbed by subarachnoid villi. Now subarachnoid villi, it is also called as subarachnoid granulation, or it is also called as pachyonian granulation. Pachyonian granulation. Now, out of 720 ml, 500 ml is reabsorbed in the subarachnoid villi or subarachnoid granulation, or it is also termed as pachyonian granulation, while remaining 120 ml, it is present in subarachnoid space, and the subarachnoid space, the major function of CSF, that is protection. That is protection of CNS. That is brain and spinal cord. So I repeat, the rate of production is 0.5 ml per minute, 30 ml per hour, or 720 ml per day. Out of 720 ml, the 500 ml it is reabsorbed by subarachnoid villi or granulation or pachyonian granulation, while remaining 120 ml it is constantly present in the subarachnoid space, where it helps in the protection of brain and spinal cord. Now let's discuss the flow of CSF, or rate of production of CSF and its flow. Now we will be discussing the flow of CSF. Now, CSF, it is a cerebrospinal fluid, and it is produced by a bunch of capillaries that is termed as choroid plexus. Now, let's discuss the flow of CSF. Now, let's say we have a cross-section of brain. Cross-section of brain means we cut the brain, and now we split the brain and we see it from the above. So, how the brain would be look like? In that condition, let's say this is a cross-section of brain, and it is just look like a heart. Now, this is the cross-section view of the brain. Now, this portion is called as right. This portion is called as right cerebral hemisphere. This portion is called as left cerebral hemisphere. Now, this outer lining, it is covered by a different layers, and that is termed as meninges. So, it is covered by meninges. And what is meninges? Meninges are the covering of brain and spinal cord. So in meninges there are different layers, like there is pia mater, arachnoid mater, and dura mater. Now the inside layer, that is called as pia mater. Outside of pia mater there is arachnoid mater. Outside of the arachnoid mater there is dura mater. Now the point is, in between the pia mater and arachnoid mater, that area is called a subarachnoid space. So it is important. The space between the pia mater and arachnoid mater, that is called a subarachnoid space, where the CSF will be floating. Now, there is also there is brain parenchyma. Inside the brain parenchyma there are a collection of neurons. Like let's say there would be collection of cell bodies. There would be a collection of axons, and it is spread throughout the brain parenchyma. Now these are cell bodies. So the collection of cell bodies, that is called as gray matter, while the collection of axons, that is termed as white matter. So gray matter and white matter, it is constantly present inside. Now inside the brain parenchyma there is ventricles. So this is called as ventricles. What is ventricles? These are irregular cavities which are located within the brain parenchyma. Now, just over and above the level of ventricles, there are bunch of capillaries are present, and that bunch of capillaries, that are termed as choroid plexus. So this is called as choroid plexus. And what is choroid plexus? These are the bunch of capillaries, and somehow it consists of 30 to 40 capillaries, and it is lined by single layer of endothelium. Choroid plexus, it is lined by single layer of endothelium. And what is the major function of choroid plexus? It produces the CSF. Now further, the choroid plexus, it comprises of anterior choroidal artery. It comprises of anterior choroidal artery, and it consists of posterior, medial, and lateral medial So I repeat, the CSF, it is produced by a bunch of capillaries that is termed as choroid plexus. After that, the CSF shift to the lateral ventricle, and it is important that the maximum CSF it is produced in the lateral ventricle. After that, the CSF shift to the third ventricle with the help of foramina that is termed as foramen of Munro or interventricular foramina. After that, the CSF shift to the third ventricle, and then from third ventricle it reaches to the fourth ventricle through the junction of cerebral aqueduct of sylvious. After that, the CSF enters into subarachnoid space with the help of foramen megendie and foramen luschka. Now, in the cerebral arachnoid space, there is subarachnoid villi which helps in the absorption of CSF. Then it enters into jugular vein, superior vena cava, and ultimately reach to the right atrium. Now, this is the normal pathway of the flow of CSF. Now there is another important question: what is the serum marker for the hydrocephalus? So always remember that the serum marker for the hydrocephalus that is called as beta-2 transferrin. Now let's discuss the certain causes of hydrocephalus. Now what is the etiology of hydrocephalus? So the causes of hydrocephalus, it is divided into two groups that is called as congenital causes and acquired causes. Now let's discuss the causes of hydrocephalus. Now, the causes of hydrocephalus that is called as congenital causes, and there is acquired causes. Now, and congenital causes, the most common cause of hydrocephalus that is called as congenital aqueductal stenosis. Now, as you know that cerebral aqueduct of sylvious, it is the foramina, it is the junction which actually the in between the third ventricle and fourth ventricle. As I told you earlier, there is a lateral ventricle. That lateral ventricle it communicates with the third ventricular, and after that the third ventricle it communicates with the fourth ventricle. Now, in between the third ventricle and fourth ventricle, there is a junction or foramina that is called as cerebral aqueduct. Now, if there is stenosis or nerving occur in cerebral aqueduct, so what happens that the CSF, there will be the accumulation of CSF occur, ultimately it lead to the hydrocephalus. Now it is the most common cause of congenital hydrocephalus. Secondly, the another cause is that is called as Dandy-Walker syndrome. Dandy-Walker syndrome. Now what happens in Dandy-Walker syndrome? Here there is congenital stenosis occur. Congenital stenosis occur in foramina, luschka, and foramen megendie. Now, as you know that the CSF it shifts to subarachnoid space from the fourth ventricle with the help of foramen luschka and foramen megendie. Now, what happens if there is stenosis occur? It means if there is a nerving or obstruction occur in the foramen megendie and luschka. So what happens that the CSF accumulation occur, which lead to the hydrocephalus condition. Now it is also considered as one of the congenital cause of hydrocephalus. The other cause is that is called as Arnold-Chiari syndrome. Now in Arnold-Chiari syndrome, what happens? There is brainstem herniation. Brainstem herniation resulting obstruction in subarachnoid space. Now there are three causes of congenital hydrocephalus. The first is that is called as congenital aqueduct stenosis. It is the most common cause of congenital hydrocephalus. Secondly, there is Dandy-Walker syndrome. Here there is stenosis occur in foramen megendie and luschka. And there is Arnold-Chiari syndrome, where there is herniation of brainstem occur, which lead to obstruction in subarachnoid space. Now let's discuss the acquired causes of hydrocephalus. Now the acquired causes contain the intraventricular hemorrhage. Intraventricular hemorrhage is the most common cause of acquired hydrocephalus. Also, meningitis and brain tumors. It leads to the acquired hydrocephalus. Now let's discuss the types of hydrocephalus. How many types of hydrocephalus are there? So there are 4 types of hydrocephalus. Let's discuss the types of hydrocephalus. Now, the first cause is that is called as communicating hydrocephalus, and it is also called as non-obstructive hydrocephalus. Now, communicating hydrocephalus means that the ventricles, that is lateral ventricle, third ventricle and fourth ventricle, it means that the ventricles are communicating with each other. It means there is no any obstruction here. That's the reason there is no any obstruction in the flow of CSF. That is why it is termed as non-obstructive hydrocephalus. So it means that in communicating hydrocephalus, the outflow is normal. Outflow is normal. Now, if outflow is normal, so what is the main reason behind communicating hydrocephalus? So the main reason behind communicating hydrocephalus, that is overproduction of CSF. Either there is CSF production is high, or there is impaired absorption of CSF. Impaired absorption of CSF. Now, what are the causes of communicating hydrocephalus? That is choroid plexus, papilloma, villus hypertrophy, and certain infections. So, in communicating hydrocephalus, the ventricles are communicating with each other, but here actually the CSF production is high, or there is impaired absorption of CSF, which lead to the increased size of ventricles, which lead to the enlargement of the ventricles. Now, what are the causes of communicating hydrocephalus? That is choroid plexus, papilloma, villus hypertrophy, and infection. And always remember that the communicating hydrocephalus, it is the most common type of hydrocephalus. It is the most common type of hydrocephalus. Now let's discuss the second type of hydrocephalus, that is called as non-communicating hydrocephalus, or it is also called as obstructive hydrocephalus. It means that the ventricles are not communicating with each other. It means their outflow is not normal. It means there is obstruction occurring in outflow. So there is the outflow is obstructed, while the CSF production is almost normal. And what is the most common what is the most common cause of non-communicating hydrocephalus? That is aqueductal stenosis. So aqueductal stenosis, it is the most common cause of non-communicating hydrocephalus, and it is the rare type of hydrocephalus. It is the rare type of hydrocephalus, but it is the most dangerous type of hydrocephalus. Now, till now we discussed the two types of hydrocephalus, that is communicating hydrocephalus and non-communicating hydrocephalus. Now there is third type of hydrocephalus, that is called as normal pressure hydrocephalus. So what is the another type of hydrocephalus? That is called normal pressure hydrocephalus. Now, normal pressure hydrocephalus, it is the most dangerous type, and it is actually the type of communicating hydrocephalus. It is the type of communicating hydrocephalus. It means that the ventricles are communicating. It means the outflow is normal, but the only problem is that there is either excessive production of CSF or there is impaired absorption of CSF, which lead to the enlargement of the ventricles. So now, if the patient is suffering from the normal pressure hydrocephalus, so there are certain important clinical manifestation of a patient, and that clinical manifestation and that clinical presentation, that is called as Adams triad. That is called as Adams triad, which is also called as Hakim triad. So it is very, very important. The Hakim triad or Adams triad, it is associated with the normal pressure hydrocephalus. Here, the triad consists of gait deviation, dementia, and urinary incontinence. So this is very important triad associated with the normal pressure hydrocephalus. Now let's discuss the last type of hydrocephalus, that is called as hydrocephalus ex vacuo. Now actually it is not true type of hydrocephalus. Here the ventricles, the brain ventricles enlarged. The brain ventricles enlarged due to atrophy of brain or schizophrenia or dementia. So in Hydrocephalus ex vecchio, it is not true type of hydrocephalus, and here the brain ventricles enlarged due to atrophy of brain or schizophrenia or dementia. So student, that is all about the types of hydrocephalus. Now let's discuss the clinical presentation of a patient if someone is suffering from the hydrocephalus. Now let's discuss the clinical presentation of a patient. Now let's discuss the clinical features. So what are the clinical features of hydrocephalus patient? So the first is the head circumference increases at a rate of 1 centimeter per week or 4 centimeter per month. So in hydrocephalus condition, the head circumference increases at a rate of 1 centimeter per week or 4 centimeter per month. So the normal head circumference is 33 to 35 centimeter. The normal head circumference is 33 to 35 centimeter. If the head circumference is less than 33 centimeter, it means there is condition of microcephaly, means small head. While if the head circumference is more than 35 centimeter, so that is called as macrocephaly. So in hydrocephalus condition, there is macrocephaly, the head circumference is more than 35 centimeter. Secondly, the anterior fontanelle is bulging. There is also frontal bossing. There is frontal bossing, and there is sitting sunshine. So there is sitting sunshine. Now what does it mean? It means upward gaze paresis. When eyes appear driven downward, so sclera is visible between eyelid and iris. So actually it is the upward gaze paresis, means when eyes appear driven downward, so what happens? So sclera is visible between upper eyelids and iris. So what is the most important and diagnostic feature of hydrocephalus patient? That is called as sitting sunshine. And sitting sunshine, when eyes appear driven downward, so sclera is visible between the upper eyelids and iris. So it is important. Secondly, there is cracking pot sound. Cracking pot sounds on head by percussion. And that condition is called as MES 1. That is called as MES 1 sign. So what is MES 1 sign? It is the cracking pot sounds on head by percussion. Also there is high pitch cry. Also there is delay suture closing. There is high pitch cry, there is delay suture closing. Now there is increased intracranial pressure as well. Now there is increased intracranial pressure. Now increased intracranial pressure lead to different clinical manifestations depending upon whether the patient is child or adult. Like if there is increased intracranial pressure, so increased intracranial pressure in child or in adult. Now what is the early sign and symptoms of increased intracranial pressure in case of child? So that is called as vomiting. Now always remember that the early sign and symptoms of increased intracranial pressure in child lead to vomiting, while in another hand the increased intracranial pressure in adult and early stages that lead to altered level of consciousness, also restlessness. Now, what are the late sign and symptom in case of child and adult? So the late sign and symptom in both cases are same. The late sign and symptoms are bradycardia. So bradycardia in child as well and in adult as well. Now I repeat, it is very important, the increased intracranial pressure in case of child lead to vomiting and early sign and symptoms basis, while later on it lead to bradycardia. While in another hand, in adult, the early sign and symptoms of increased intracranial pressure is altered level of consciousness plus restlessness, while the late sign and symptoms of increased intracranial pressure in case of adult, that is bradycardia. So late sign and symptom in both cases are same, but the early sign and symptom are different. Now there is another very important question: what are the which kind of cranial nerve is affected in hydrocephalus? So always remember that in hydrocephalus, the sixth cranial nerve is affected. Now, another important question: what are the phase of a patient if the patient is suffering of hydrocephalus condition? So that is called as Marshall Hall phase. So actually, the phase of patient in case of hydrocephalus, that is termed as Marshall Hall phase. Now, let's talk about the diagnostic evaluation of a patient if one is suffering from hydrocephalus. Now, the first of all, history is very important. The physical examination is very important. Now, let's talk about the investigation. Now, first of all, the history is very important. The physical examination is very important. And the prenatal diagnosis is confirmed by cranial ultrasonography. So the prenatal diagnosis is confirmed by cranial ultrasonography, while if we talk about an adult, so that is the confirmation is done by MRI. Also, we can do the CT scan which show the enlarged ventricles. But the X-ray is not so much effective in case of hydrocephalus. Also, we can do the lumbar puncture. But the lumbar puncture is not done. It is not done if there is increased intracranial pressure. If there is increased intracranial pressure, so in that condition, the lumbar puncture, it is not indicated. And why it is so? Because of risk of brainstem herniation. Because of risk of brainstem herniation. Also, we can do fundoscopy to assess edema behind eyes. So I repeat, what are the diagnostic evaluation of a patient? That is, first of all, history and physical examination is important, while the prenatal diagnosis, it is confirmed by cranial ultrasonography. Also, we can go for CT scan which show the enlarged ventricles, and the lumbar puncture is also important, but if there is increased intracranial pressure features, so in that condition it is not indicated. And why it is so? Because of increased risk of brainstem herniation. Also, we can go for fundoscopy to assess the edema behind the eyes. Now let's talk about the last treatment option of hydrocephalus. Now there are two approaches present for the hydrocephalus. There are two approaches for the treatment option for hydrocephalus. The first is called as pharmacological method, and there is surgical methods. Now, in the medication form, the most important drugs that is given in the case of hydrocephalus patient, that is called as acid azelumide. That is called as acid azelumide. And what is acid azelumide? It is actually carbonic anhydrase inhibitor. It is a carbonic anhydrase inhibitor. Also, it is a weak antidiuretic, and it actually decrease the production of CSF. What is the major function of acid azelumide? It decrease the production of CSF. It decrease the production of CSF as we know that the most common type of hydrocephalus, that is communicating hydrocephalus. So it is most important in communicating hydrocephalus. Communicating hydrocephalus. And what is communicating hydrocephalus? Meaning that it means that the outflow is normal, but the only problem is that the patient is suffering from the high production of CSF. So for that we need to decrease the level of CSF. So the acetazolamide, it decreases the production of CSF, is the most common form of hydrocephalus is communicating hydrocephalus. So it is play a good role while decreasing the CSF. Now what is the dose of acetazolamide? The dose of acetazolamide is 50 mg per kilogram body weight per day. So what is the dose of acetazolamide? That is 50 mg per kilogram body weight per day. Now what is the second option? That is called as mannitol. Mannitol. And what is the major action of mannitol? It decreases the intracranial pressure. It decreases the intracranial pressure. Also the third approach is that is called as furosemide. So there are three options in case of pharmacological methods: acetazolamide, mannitol, or furosemide. Acetazolamide, it decreases the production of CS. Mannitol, it decreases the level of increased level of intracranial pressure. Now let's talk about the surgical methods. And the surgical methods, there are three options available. The first is called as shunting, and the second option is that is external ventricular drainage. External ventricular drainage, and there is ventriculostomy. Ventriculostomy. Now the shunting, it is considered as the treatment of choice in case of obstructive hydrocephalus. So it is considered as the treatment of choice in case of obstructive hydrocephalus. Here the one side of the shunt, it is placed in the ventricle, and the other side it is inserted into the right atrium or peritoneal cavity. Now there are different types of shunting. The one is called as, there are two types of shunting. The one is called as ventriculoperitoneal shunting and ventriculoatrial shunting. Now which is the most common method of shunting? So it is important that ventriculoperitoneal shunting, it is the most common type of shunting. Now in ventriculoperitoneal shunting, the one side of the shunt, it is placed in the lateral ventricle, while the other side of shunting, it is placed within the peritoneal cavity. But though it is the most common type of peritoneal shunting, but it leads to certain complications. It leads to the ascites. Also it leads to abdominal pain. While in another hand, in ventricular atrial shunting, the shunting, it is done between the lateral ventricle and right atrium. So in ventriculostomy, the opening is made in ventricles, thus the CNF is drained out. So students, that is the treatment option in the form of pharmacological methods and surgical methods. So students, that's all about the hydrocephalus, and thank you so much.